Might be worthwhile.
Okay, so we have a 28-year-old man with no visual complaints. He was started on Plaquenil a few months ago for lupus. You saw an elevated lesion infranasally in the macula in the right eye. He says he's been flaring lately. It had been under control for a month with the lupus. When he flares, he mostly has trouble with his joints and gets a butterfly rash. Medical history notable for lupus, surgical history non-contributory. He's on Plaquenil, mycophenolate, mofetil, losartan, and Xarelto. Vision in the right eye is 20/25, vision in the left eye is 20/32, and IOP is normal.
Okay, so there's a color up on this photo of the right eye, the the media looks here, the nerve, here's pink, sharp, the borders. Around the macula, there appears to be like a little haze or like a circumferential, area of hypopigmentation or a little bit whiter around the fovea. And another, kind of circumferential area of like,
You can use your mouth.
Oh.
Everybody can see it.
And he is young too, so he's 28. He's on the sheen.
oh, okay, just a sheen.
That's
exactly but I feel like otherwise it looks pretty good, pretty normal.
Did you talk about this thing yet?
Oh, I thought that was an artifact.
No.
Oh, that's the nasal. That you saw. Okay.
It does look like an artifact.
So maybe an area here, infranasally, looks to be a little bit elevated.
Yeah, using 3 DQs or 2 DQs. And then what level, you can do the shape and size and edges and all that color. The color, this didn't quite capture the color. I have to say, it was a little fleshier. I wish that-
Here.
Yeah,
Like less yellowy.
yeah, it was less yellowy. It was more like kind of fleshy.
So it appears to have relatively kind of, well-defined borders.
Good.
Maybe a half disc, diameter,
Mhm.
and size.
Do you use disc diameter or disc areas?
I said diameter.
Yeah, kind of like disc areas. Because it's not really, it's, you're describing
That's true.
an area.
Yeah, it's true.
Diameter is linear.
Area is more accurate.
I like that. So it'd be about a half, a third disc area, but go ahead. And then what level? Can you tell? It's kind of an interesting lesion in that you kind of almost can tell the level.
Is it kind of?
You guys know why it's confused about
It's
this area, this diameter. It's historical. What I was, the big issue was how much NVD did you have? And
Oh, for the
eventually-
disc areas.
And it's always in disc area. You had to have about a third to a half to meet the DRS criteria for laser treatment. And the truth is, if you can see any NVD, you've got
Trouble.
Yeah.
You know,
So you were saying the level, so what level is that? Intraretinal, subretinal, or preretinal?
I feel like I can see kind of the vessels a little overlying it at the edges, but it seems to be
no, you can't.
on the side.
On the side.
On the side, but in the middle,
Active imagination.
look at the vessel up here on top. Whoops, I'm sorry.
Yeah, some you can, some you can't.
Yeah, so the vessel on top, you can kind of follow the vessel, right? But this vessel, if you follow it, it's like, huh, I wonder what it did. And this
It's like you
vessel.
put a napkin over it, over the vessel.
Okay.
Well, he's not showing you stereo, so that's
Yeah.
a big problem.
Yeah.
He's gonna make up for.
When
that.
we started, I used to bring, 30 years ago, I would bring slides in the stereo viewer.
Well, you can do stereo slides up here, you just sort of have
That's
something
always
funny
the
with
one
your
for
eyes, I could never
Ralph.
figure it out, but I did.
Yeah.
Never forget.
Yeah, you just.
All right, so go ahead.
If it's above the vessels, then
Yeah.
you do that.
Mhm. Okay.
You're using monocular clues. He's gonna give you an OCT or something and then you'll know.
Yeah, so I think you described it well. So it's smooth, it's about half or a third disc area or diameters, and then it seems to be mostly retinal.
You forgot one important characteristic.
It,
The edges, are they sharp or fuzzy?
they look sharp.
Yeah.
Mhm.
That's probably something you'd wanna mention.
And then a color fundus photo of the left eye, the media looks clear, nerves look pink and sharp. And also you're getting that, sheen of view that we see here. Otherwise, I think the macula, is good, the vessels, kind of look within normal limits as well.
Can you go back one slide? I just want to go over, I know I've said this a lot. I don't know if I've said this here yet. When you're talking about lesions and you're on the board and there's lots of people staring at you and you don't know exactly what it is, go through the same thing every time. 6 things in order: size, color, borders, depth, elevation, and the company it keeps every time. And as you go through that, it's like your brain's doing a Rolodex and you'll come up with a couple of answers and you won't fail your boards.
Those size, color.
Size, color, borders, depth, elevation, and the company it keeps. Is it near the nerves? Is it near vessels? Are there other lesions like it around it? And that's how you describe a lesion. You go through that and you can't get any of that wrong. You can just get your diagnosis wrong, but you're more likely to come up with a better differential if you just take your time and go through it, I think.
So what'd you do for this one?
I would say third disc area, yellow, fuzzy borders. It's superficial because it looks like it's a napkin over the vessels. Best as I can tell, it's flat because it's all in focus. And it's associated with the juxtafoveal area.
It's not
of
fuzzy
vessels.
borders, I disagree. So Rathanasamy, you guys know Rathanasamy, is he still attended the VA?
Yeah.
So one day he called me up, he's a resident, and I did that. I got this lesion and he said, well, what's it like? And he said, when it sort of looks like a headlight through a fog.
Did he say that?
Yeah, he said it, and then he said, oh. Just like that.
I like that guy.
So, in other words, just by describing it, he got himself to where he needed to be.
Yeah. That's the idea. By describing it, you'll get where you need to be. Yeah. Does he attend the VA? I like Phil. He was training 2 or 3 years after.
Yeah, I go by Swan,
Yeah.
there's a clinic there. There are 9 names up there.
Yeah.
5 I helped train.
Wow.
Maybe not a lot of help,
Cool.
but they went through the program when I was
That's cool.
All right, so keep rolling. You're doing well. All right, so this is helpful.
Yes.
Okay, so this is an OCT, of the right eye. At the layer of like the inner kind of RNFL, if you like, you can see,
Yeah, thank you again. Take care. I'll let you know what.
almost this like homogeneous kind of protrusion, kind of extending. A little bit of distortion of the outer kind of layers as well, caused by this, but otherwise it seems like the architecture, not the outer layers are well preserved.
And you don't see cells around it or edema, like if it were a, fungus ball or some infection, you'd expect to see it. It's pretty non-reactive.
So this is the vertical
Yes.
slice of the OCT of the right eye. Again, I think similar kind of protrusion, almost like homogeneous appearance of this RNFL layer that's causing distortion of the layers below it as well.
borders.
The borders appear kind of well demarcated, maybe a little bit hazy inferiorly, but it's well demarcated.
Yeah.
And then an OCT of the left eye, architecture of the retinal layers appears to be well preserved here, good foveal contour.
Any Plaquenil toxicity? Good. I had a patient referred once with a dislocated IOL who had new onset wet AMD. So I always get those CT scans. You don't wanna miss the other diagnoses, you gotta,
Mhm.
cause you figure if you're only doing the eye, you gotta cover everything.
Okay, so summary, 28-year-old asymptomatic male evaluated for routine plaquenil screening, past medical history is notable for lupus on plaquenil, mycophenolate, moptil. Vision is good. Fundus photo showed the elevated white yellow, but I guess more fleshy in real life. Lesion with sharp borders in the infranasal macula. The OCT showed predominantly hyperreflective dome-shaped thickening localized mainly to the retinal nerve fiber layer, but there was some nerve distortion of the ganglion cell layer and the interretinal layers.
Very differential. Can't think off the top of my head of stuff that would cause localized,
So I split it based on kind of what we talked about in terms of like infectious, etiology, inflammatory, and then proliferative or the neoplastic. So if we kind of go through potential
It's sort of the
infectious-
house, it's the house.
Yeah.
differential.
Yeah,
Lupus. I guess it is.
yeah, he has lupus, so it would be like an inflammatory picture from his lupus or.
other kind of. Maybe like syphilis, sarcoid, those kind of pictures that are, little. Have different presentations, you said neoplastic causes as well, ones that target the RNFL, not too familiar with,
And it doesn't have to be malignant, it could be benign.
okay. Hmm.
That's pretty good.
It's a tough one. It's a
Yeah,
funny
it's
looking
tough
spot.
one.
Yeah, there's no like classic picture of this and like what we normally see.
Right, this one looks a little different from how it's supposed to look too.
Yeah, it's not that, I feel like the classic ones we see in like a
They're slightly different.
flashcard or something.
And I feel like they're usually more peripheral to the flashcards.
No, it's in the
No,
posterior.
or at least the.
I think it's the
Okay.
location. There's one thing
Yeah.
about this one, look, I think is a little different.
Okay, I'll help out a little bit.
Sure, go ahead.
Okay, so, differential, so, white, yellow, or even fleshy retinal lesions, so infectious, could be a chorioretinitis, but we didn't really see any, bit cell here. And he's asymptomatic, healthy, is showing up in an outpatient setting, endogenous endophthalmitis, inflammatory, for lupus retinopathy, cotton wool spots typically on the RNFL, but those would have more of a fluffy border, hard exudates. Proliferative, so myelinated nerve fiber, layer, retinoblastoma, retinocytoma, astrocytoma, and then I just put uveal melanoma and choroidal mets in there, even though it's not a retinal lesion, but just to kind of keep in the back of your mind if you just, I think you got masses. So it's a retinal astrocytoma or retinal astrocytic hamartoma, and to review, a hamartoma is abnormal proliferation of normal tissue in normal location. It's a benign glial cell tumor, and mainly of astrocytes, that's the name. The three subtypes, I found this helpful because I feel like I've mainly only seen type 2, the mulberry-like one, in pictures.
Right,
Yeah.
that's much more common. This was a funny one.
Even though.
And I have to say retinocytoma, I was thinking of retinocytoma, but retinocytomas, which are really rare, only form when they calcify. So retinocytoma is a regressed retinoblastoma. So retinoblastoma forms and then it regresses, but the regression pattern always has calcium. So this one really can't be a retinocytoma, so it has to be, the only other choice is an astrocytoma, I think.
So, type 1, so I saw that type 1 was the most common, which is similar to what this gentleman had, so flat, smooth, clear borders, semi-translucent, and a more of that kind of gray-white lesion, which it sounds like was the case for the gentleman, without calcifications. Type 2, I feel like is the one we typically think of, so it's mulberry-like, raised, nodular, opaque, and then the lesions have calcifications. Type 3 is kind of a mix between the two with features of both. Typically asymptomatic, unless it's causing complications or based on location. So they typically don't progress, they remain stable throughout life, but uncommon complications, mainly to consider is like CNVM, stative RDs, and you would only treat it if it's causing any of these complications. Otherwise you would just observe. And the OCT picture I showed here was just of a different one. So this one would have the cavitations as opposed to just the kind of more homogeneous hyperreflective dome. This is just another version of it. So in terms of pictures, this I just got off of iWiki, but in terms of the color photos, for type 1, similar to the one our gentleman had, if you look at the left eye and that kind of infratemporal kind of area, that's similar. So it's the kind of smooth, no calcification, semi-translucent, as opposed to all of the other ones in both eyes are that more nodular kind of mulberry picture that I feel like we've seen more. And then for autofluorescence, if there's calcifications, we would expect that hyper autofluorescence. And so those are great pictures to kind of just compare. That's another one. That's another one. That's just nasal there, the left eye.
Yeah.
Yeah. So the most common systemic association is tuberous sclerosis. It's also been reported in other kind of syndromes, mainly NF1, but also RP, Usher, Stargardt, and gyrate atrophy. And even though we just did OCAPS, here's just a review of tuberous sclerosis.
How'd you guys do? Was it okay? Can you tell? They don't grade you right away, do they?
I think we just got them back like 2 days ago. Yeah, I don't know, I wasn't there yesterday here, I don't know what they mentioned.
Yeah.
That's pretty fast, isn't it?
Yeah,
It should be instantaneous.
it's 2 weeks.
Just so you're clicking on a computer. right?
Yeah.
So you guys probably already remember this, but it's related to the TSC1 and TSC2 tumor suppressor genes that encode hamartin and tuberin. It works on the mTOR pathway. Autosomal dominant or sporadic, and then it has variable expressivity. So many different kind of systemic findings for the eyes, mainly the retinal astrocytic hamartoma. For the brain, you always have seizures, intellectual disability. The skin, I feel like they'll show these all the time. So the top photo is the actually spot that hypopigmented macule. The shagreen patch is that kind of leathery patch on the back. Facial angiofibromas is always described as acne. It looks like acne. So if you see a picture of that, think tuberous sclerosis. And then cardiac rhabdomyoma is also, I feel like, always talked about on test questions. And then Erno et al. Was looking specifically at tuberous sclerosis patients, and of those, about a third had the retinal astrocytic hamartoma, 43% were bilateral, and then 40% had multiple tumors, on average 4. And in terms of size, about 1 disc diameter, the range was about half to like 2.5. And that's it, pretty short. It was a hard one.
Yeah,
And
I wouldn't call that
supposed to be
intermediate.
for Matt too.
So you were right, it was partially in front of it, but, yeah.
Yeah, kind of in the retina. Yeah, very nicely done. All right.